questions. If you want to ask the questions, you want to discuss in the meanwhile, you can ask by name. Dr. Bharanidharan, please answer this question. Dr. Rupesh, you can answer the see the X-ray and give your findings. Like that, you can ask in the middle. There are questions which are posted in the chat box. At the end of the session, you can summarize and ask the question to Dr. Krishna.
Okay, sir.
Yeah, sir. Now YouTube on live. Okay.
You can play the video.
Yeah. Just we start.
Once the video is over, we can start.
Yeah. Once the video you can talk about this.
Dr. Dr. Piyush, please come to the Zoom meeting. Please come quick. Program is about to start. Okay?
PT sir antarathalli. Yes, sir. Suresh sir, you can start.
Okay.
Yeah.
Good evening, everybody. Good evening, postgraduates. Today, the TNOA PG teaching program's 30th program. We have a special person as a faculty, Dr. Krishna Kumar. For all of you know, to begin with study the MS Ortho, then start a good practice. That's a dream of every orthopedic surgeon. But Dr. Krishna Kumar is even gone beyond this routine expectation. He started a DNB institution on his own. A DNB institution in a place which is so remote. It is almost in the tip of this country. And it is the only DNB institution. Very few institutions in Tamil Nadu have DNB. One among them is Dr. Krishna Kumar's institution. It is because of the passion in orthopedics. I think probably it is a passion in his orthopedics which made him to start and stand unique among the rest of the orthopedic surgeons. On behalf of all of you, I welcome Dr. Krishna Kumar for this program on TB arthritis of the hip joint. If you want to tell me the academic credentials of Dr. Krishna Kumar, he has got about more than 30 or 40 as a standard as a faculty member of scientific proceedings. I can tell you a few things. He has been published a journal in the Indian Journal of Orthopaedics about the supracondylar fractures in the pediatric age group. IJO is, as you know well, is a standard journal as far as the Indian subcontinent is concerned. He has been a regular faculty of TNOA as well as IOA. He has presented many papers about segmental bone loss, compound injuries, orthofixator. I can talk many about this, replacements, many difficult surgeries, my worst complication in IOA. All those things I can narrate many things. But lack of time, I just limit to this. He has got a very good organization since this evident in the last conducted TNOA in the February in NAGERCOIL. And of course, I introduce Dr. Sastha Krishna Kumar. He is our young moderator. He has finished his MS Ortho from Ramachandra Medical College. He has presented a paper on proximal femur osteodystrophy, and he's also presented a paper in YSSCon as well as in TNOA. He underwent AO spine surgery course in Colombo as well as in India. He has been working as a junior consultant in Dr. Krishna Kumar Institute. I think today they will do a great job in dealing with TB hip. As I have posted in the WhatsApp group, it is a very important topic. So now I invite Dr. Sastha to take over these proceedings and go ahead.
Okay. Thank you, sir. Good evening, respected teachers, colleagues, friends, and indeed it's an great honor to give me uh, this post being a moderator for this session. I'd like to, as Dr. Suresh sir has already gave a brief introduction about our speaker, I straight away hand over the session to our speaker, Dr. S Krishna Kumar, to start the session. Over to Dr. S Krishna Kumar.
Good evening. Am I audible and am I
Yes, sir.
Yes, sir.
you
Audible,
are-
sir.
you
Audible.
are
Sir.
audible.
visible? Fine.
Yes, yes.
Good evening, everybody. And it's a pleasure to be with you today. And I should appreciate the Tamil Nadu Orthopaedic Association for organizing a teaching program for postgraduates. When all doors are shut, we will open another door. That's a good attitude. I should congratulate the office bearers for taking this initiative. And Alembic is our academic partners in everything. And I thank Alembic for giving this platform for us to interact. Now, let us go into the subject. See, this, I should appreciate the organization of this teaching programs. Last week or 2 days back, Dr. Anil Thomas had discussed well about clinical case taking. And after that, one by one, you are introducing the topics of HIP. He has discussed about HIP, history taking, and clinical examination. And now, when we talk about tuberculosis and next another topic on HIP, the postgraduates will get a very good orientation so that they can present their cases very well. So that is a very good initiative. Now let me go to the subject proper. Yeah, is my screen visible? Hello?
No,
You are visible, sir.
Not yet, sir. No. Yeah,
Oh,
you're visible, but the screen
share.
is not visible.
Screen
Sir.
is not visible.
Screen is not visible?
Start the
Yes, sir.
PowerPoint.
Yeah, I have started PowerPoint.
No. First screen sharing, sir. Then PowerPoint, sir.
Okay. Sorry. Yeah, we are all still.
Share screen. Share screen, sir. Green mark in the down.
Yes, okay. And then
Yes, sir. Now,
Yes, sir. Yeah,
yes.
visual, sir.
Now your screen is open. Open the PowerPoint, sir. Yes.
Screen visible,
No, sir. Yeah.
Yes. Come down, sir. You'll find it. Yes, sir. That is one. TB hip, sir.
Fine. Visible now?
Yeah.
Yes, sir. Go to the first slide. Now, third slide, sir. Now go to the first slide, sir. From beginning. Yes, sir. Yeah.
Yes, sir.
Okay.
Perfect. Sir.
Yeah, fine, nice. See, tuberculosis of the hip is a very important topic for the postgraduates as well as practicing doctors. Why? The examiners like this topic. So naturally, the students should also like this topic. And the second reason is early diagnosis can save the hip. Patient can have a normal hip if you can diagnose and treat him properly. And thirdly, India stands first in the global incidence of drug-resistant tuberculosis. And you see the values, 27%, China is 14%, almost 50% less, and Russia is 9%. The difference is quite obvious. This is Global TB Report 2019. We as doctors or orthopedic surgeons should contribute something to reduce this percentage. Coming to our clinical cases, this is roughly the types of clinical cases you will get in your exam. On the trauma side, it is neglected fracture neck of femur, etc. On cold orthopedics, if there is a case of tuberculosis of the hip in the ward, you will definitely get that case selected for the exam. Because tuberculosis of the hip is one condition where there are a lot of findings which can help the examiner to assess the clinical acumen of the candidate. So it is, yeah, now I will call upon one of the postgraduates who are willing to interact. One is Dr. Bharanidharan, available?
Yes, sir, available.
Okay. This is for Dr. Bharanidharan. So you have a look at this X-ray. The clinical points are there. 21-year-old male, he was operated for a malignant tumor of the brain 2 months back. And he came to us on 26th March, 22 days after the lockdown. Following the surgery, he developed meningitis and he was started on antibiotics and steroids. He developed pain in right hip and left knee. He was started on ATT. I will tell you why I have put it in red. There is no fever. The right hip movements are restricted and painful, and the left hip, left knee is in effusion. ESR and CRP are raised. Now I will give you 1 minute time. You can start writing down the points. Just concentrate on the right hip. Ready, Bharanidharan?
Okay, I'm ready, sir.
Yeah.
Sir, you want the X-ray findings from Bharanidharan, sir?
Yeah, you can write it down. We will discuss about it later. Right now,
Oh, okay, sir. Okay.
Okay,
You
sir.
want
Okay,
me to
sir.
write him the paper? Okay,
yeah,
fine.
write it down. Over.
Yes, sir, noted, sir.
Okay. So now I will give you another 1 minute. You can write down the possible differential diagnosis. Your 1 minute starts now.
Okay.
Over.
Okay, sir.
Okay, fine. Now we'll go to the next slide. And this slide is for Dr. Piyush. Available? Mangalore?
Piyush,
Is not available, sir.
Fine.
not available.
Fine.
Dr.
You
Rupesh
can
is
ask Rupesh is available.
Rubesh. Switch over to Dr. Rubesh. Dr. Rubesh?
Yes, sir. I'm available, sir.
Yeah. See, now don't have to write any findings. I will give you the findings. This is 71-year-old male, recent onset of low backache, radiating to both thighs, history of fever present, lumbar spine is stiff, and he has some weakness. ESR and CRP are raised. The findings are, you see all the discs are degenerated. This is T2 weighted image. And in this disc, L45 disc, there is an erosion in the upper end plate And you see some fluid collection as evidenced by hyper intense signal. This film shows a good collection, a pocket over here compressing on the dura. And this is a transverse view which shows that there is a complete disorganization at this level. Okay, now I will give you, this is again the same thing. I will give you 1 minute now. You can, Rupesh, ready?
Yes, sir.
Yeah, 1 minute now. You write down the possible differential diagnosis.
Dr. Rupesh, have you noted down the differential diagnosis?
Yes, sir.
Over?
Yes, sir.
Okay, fine. We'll move on to the next slide. We'll come and discuss about these cases at the end. Right now, there is nothing much to say that, except that this is always a multi-system disease. So when you are thinking about tuberculosis of the hip, think it as a multi-system disease because it is always secondary. Now we all know that we live in an environment of tuberculosis. The air around us is fully loaded with tuberculosis, and most of us do not develop tuberculosis just because our immune system is strong enough. But when you put the patient on immunosuppression, or when the patient is having HIV, or when you treat a patient who is having an inflammatory disorder like rheumatoid arthritis or any of the seronegative or seropositive arthritis, you put them on anti-inflammatory, not anti-inflammatory, put them on immunosuppressants like methotrexate, and particularly the latest biologics like TNF-alpha blockers. Before you put them on TNF-alpha blockers, you should check whether they have any focus of tuberculosis. And when you put them on drugs like methotrexate or TNF-alpha blockers, there is chances that the tuberculous lesion which was lurking in them could get reactivated. And this will give you a diagnostic dilemma whether the problem is an exacerbation of the arthritis or it is an infection, tuberculous infection. So about the pathology, I will just go through a few slides. About the pathology is always blood spread. It can involve the synovium or the bone. In children, it is the metaphysis which is involved. In adults, it's the epiphyseal region. And because there is no proteolytic enzymes synthesized by the organism, the cartilage damage is late. And that is why an early diagnosis can prevent a total damage to the joint. This I have copied from Tuli. These are the common sites where you get the infection. And this is about the pathology. It's a very simple, you will get 1 mark if you draw this diagram in the exam. A central area of caseation necrosis, just 4 points, surrounded by epithelioid cells. Surrounded by epithelioid cells, Langhans giant cells, and heavy infiltration with lymphocytes. These 4 points. Tuberculosis never produces a sequestrum. The sequestrum is, if at all is produced, it's only a sandy sequestrum, and rice bodies are usually seen in compound palmar ganglion. There is synovitis, tuberculous synovitis of the flexor tendon. So for all practical purposes, tuberculosis does not produce sequestrum like pyogenic osteomyelitis. So this is a one point, remember. CD4 count below 20 indicates poor prognosis. So it is worthwhile when you do a blood count, blood examination, do a CD4 count as well. About Manto, diagnosis of tuberculosis, we are all told that a positive Manto does not signify anything, whereas a negative Manto will indicate that the patient does not have tuberculosis. It's not true. Disseminated tuberculosis, particularly in a very high immunodeficient patients on long-term steroids and severe malnutrition, will not develop this. After all, this is a reaction, immune reaction to the agent which we are given. And so when there is no immunity, this will be negative. So these are the areas, these are the times when the Manto is negative, and so a negative Manto does not signify that the patient does not have tuberculosis. So when you are treating a patient with tuberculosis and if the patient is not improving, it means that the diagnosis is wrong or the patient is having atypical tuberculosis, and you will be surprised to know that tuberculosis of bovine tuberculosis is quite common in Tamil Nadu. In an area near Kudangulam belt, there is quite a large number of patients with atypical tuberculosis infections. Mycobacterium tuberculosis is just about atypical tuberculosis mycobacteria. They are also called atypical mycobacteria, non-tuberculous mycobacteria, or environmental mycobacteria because they are present in environment quite commonly. Pathology of the disease. Why should you know the pathology? Any classification should give you an idea about the prognosis or the treatment protocol. You should know the stages of the disease, tuberculosis of the hip, so that you will decide what treatment is best. So these are the 5 stages of tuberculosis of the hip: synovitis, early arthritis, late arthritis, subluxation, dislocation, and gross deformity and ankylosis. There is a fine end stage or the burnt out case. Synovitis, there is spasm. It usually said that the patient will have flexor spasm and extension is the first movement that is lost. Why? The psoas is just applied over to the anterior surface of the hip joint, just anterior to the capsule. So any inflammation will produce a spasm of the psoas, and flexion is, you will get a flexor spasm. So extension becomes restricted. So during synovitis, this is a very, very classical sign that the patient will have a range of movement which is not normal when compared to the other side. There will be some restriction, but whatever range of movement he has, that range of movement is painless. That is because there is no arthritis. The bone, raw bone is not grinding against each other. The pain comes only when the capsule gets stretched at the terminal range of the available movement. So in X-ray, you will see only soft tissue swelling, but MRI is diagnostic. So this condition, particularly in a child, you should be able to differentiate between transient synovitis, following Steffi-Perthes disease, or synovitis of arthritis, rheumatoid arthritis, or inflammatory arthritis. Early arthritis, the joint damage has started, and here the hip will go for adduction and internal rotation. That is because of flexor spasm. The deformity is not severe. With traction, it is possible to correct the deformity. Pain will be there throughout the range of movement that is available, but that will be not very severe. So X-ray will show osteoporosis, and MRI will show bone edema. It is not bony edema, it is bone edema. So advanced arthritis, the deformity becomes severe. The adduction, flexion adduction in internal rotation becomes severe. And to go back, in synovitis, you have flexion, abduction in the external rotation. In arthritis, you have flexion, adduction in internal rotation. So here the deformity becomes severe. In a less advanced arthritis, your deformity is correctable with traction. Here it's not correctable. There is severe muscle wasting, the capsule becomes contracted, and the deformity becomes permanent. So this is a stage where there is permanent destruction of the femoral head and acetabulum, where the joint cannot be saved. So advanced arthritis, this is only part of advanced arthritis. You can go for subluxation or dislocation. Now the treatment becomes a little more complicated. That is why this classification is a valid classification. Further joint destruction is there, wandering acetabulum, protrusia, etc. Then finally it goes for fibrous ankylosing. I am very lucky, and some of us are very lucky to work under Professor TKS, and he is one who has given the radiological classification. It is worth remembering this. We'll give you the diagram. So this is normal hip. Type 1 is normal hip. The type 2 is traveling acetabulum or wandering acetabulum. It's not the acetabulum which is wandering. Professor TK has given a catchy name. That's traveling or wandering acetabulum. It is the head which is wandering. The third is dislocating hip. And the fourth is Perthes type. The Perthes type is not because of the destruction of the head by the infection. It is because of endarteritis and a Perthes lesion superimposed on a pediatric hip which is having tuberculosis. You should take it like this. It can also produce protrusio acetabulum. There is an atrophic type and modern vessel type. Modern vessel type is the head is completely absorbed, only the neck is remaining, so it becomes something like a modern vessel. So this classification is worth remembering. How do you diagnose a case? Routine blood count, you will see only lymphocytosis. ESR is usually raised, and ESR may not be raised. Similarly, CRP may or may not be raised. A plain X-ray is the first investigation you will do. The plain X-ray will show you a lot of information. Okay, there will be periarticular osteoporosis. There can be lesions inside the head or in the acetabulum. You will see a soft tissue swelling. There are a lot of information. Though they are not very specific, it can tell you to form a diagnosis that there is something wrong with the hip. Synovial fluid analysis is very, very important. You can put a needle and get a synovial fluid and send it for PCR. And if PCR is positive, it is confirmatory and you can start them on antituberculous treatment. Biopsy again, you can take a biopsy from the lesion, so a small incision. Smear culture, guinea pig inoculation. So it is said that any one of these, like a synovial fluid PCR, bone or lymph node biopsy, you can take a biopsy from the regional lymph node. You can take a smear, look for real Nielsen staining, culture, guinea pig inoculation. Ultrasound is very, very useful, non-invasive, very, very useful. So you should establish the diagnosis that this is tuberculosis before starting antituberculous treatment. National Tuberculosis Eradication Program, the latest program, says that Inox, rifampicin, ethambutol, and pyrazinamide are the first-line drugs. We'll come to the protocol. This slide I have got it from the National Institute of Tuberculosis and Respiratory Diseases, New Delhi. I have put this slide particularly for one important thing. Fluoroquinolones, which we commonly use in our day-to-day practice, are second-line drugs used for MDR tuberculosis. So when you are using linezolid or any of the fluoroquinolones, be cautious. If you can use another fluoroquinolones, it's better because these are MDR second-line drugs for the MDR tuberculosis. Immune modulators. Immune modulators in MDR, if the patient is not, if you know that the patient is having tuberculosis and he is not responding to tuberculosis, it means that the patient is having an MDR tuberculosis or possibly a atypical tuberculosis. So if it is MDR tuberculosis, this is a protocol that is designed to improve the immunological status of the patient. After all, tuberculosis is a disease where the immunology plays a major vital part. Let us come, I will talk something about the clinical diagnosis. Suspicion is the key to the diagnosis. So you should suspect. And good history taking is essential for good diagnosis. The complaints with which the patient comes are pain. And because of the pain, he may have a limp. And because of the pain, he may not be able to walk. So the principal complaint is pain. So when a patient is complaining of pain in the hip region, it is necessary that you should exclude other causes of pain that may be referred to the hip region before you come to conclusion that the hip is the place of origin of pain. History of trauma. I usually stress very much about the history of trauma. Patients usually attribute everything to their trauma, which could be severe, which could be not related to the present complaint, which could be not anywhere near the time of the complaint, very remote. So when a patient says that he had a history of trauma before the onset of symptoms, go deep into the history and find out whether he could walk after the injury or he was taken to the hospital where any immobilization was done. These things will tell you whether the history of trauma was significant. The source of pain, before you come to the conclusion that the source of pain is in the hip region, these are the areas you will have to suspect. Lumbar spine can be the source, sacroiliac joint, hip or iliopsoas or any retroperitoneal structures. So lumbar spine, typical nerve root distribution will be there. It will be radiating along the posterior aspect of the thigh and leg and end on the lateral aspect of the foot. Neurological claudication occurs in canal stenosis. There is no nerve root distribution. Sensory impairment will be there. It will have a nerve root distribution. Radiation is posterior in L5 and S1, whereas it's anterior in L4. It typically radiates to the hip region, anterior aspect of the hip region, and it can mislead the examiner that it is a hip pathology. Sacroiliac joints, it could be unilateral or bilateral. The radiation is to the gluteal region or at the maximum to the back of thigh, never down. And there is no sensory deficit, there is no neurological deficit. In psoas abscess, most of the time, young children are brought to the clinic OPD with severe pain in the hip region. The hip is kept flexed. And the diagnosis could be a transient synovitis, a acute hygienic septic arthritis, it could be tuberculous arthritis, or it could be a split capital femoral epiphysis or a Perthes disease early stage. But what will give you a difference between any of these conditions is put your hand just above the inguinal ligament. You see an abscess there and severe tenderness there. And ultrasound will clinch the diagnosis. So this is one of the differential diagnoses you should think of when you are dealing with the hip arthritis. Very classically, the pain in the hip may be in the inguinal region. It radiates to the medial aspect into the knee. And many patients present with knee pain, and the knee is absolutely silent, and you examine properly, the pathology is in the hip. Never miss the hip examination when a patient comes with knee pain. There are a lot of similarities between tuberculosis and rheumatoid in the hip region, and it is often difficult to differentiate between a rheumatoid, monoarticular rheumatoid of the hip and tuberculosis of the hip. It's quite difficult. Fever will be present in both, can be present in both. ES or CRP may be increased in both. X-ray also will be looking similar. So it's difficult. I will come to this point once again later. So the differential diagnosis should be these things. So avian, if you pay little attention, you will see that the collapse is in the superolateral aspect of the head of femur. So treatment, I said once again. So this is the present protocol. For your theory, this is the present protocol introduced in 2019. INH, rifampicin, ethambutol, pyrazinamide for 4 drugs for 2 months. Cut pyrazinamide and continue for another 4 months, 6 months regime. And this is true for pulmonary as well as extrapulmonary tuberculosis. And you should remember INH, rifampicin, pyrazinamide or hepatotoxic drugs, and in combination they can produce a synergistic effect. So what is the treatment for tuberculosis? It depends on the stage, age, and whether there is deformity. These are the 3 criteria on which you decide the treatment. After having made a diagnosis, you start the patient on antituberculous treatment. And in a synovitis stage in a very young child, you can put them on hip spica in corrected position. Or if the child is little older, you can put them on traction. Traction will help prevent the pain, the patient will be comfortable, and prevent the deformities. So in a word, what I mean is children below, before the epiphyseal fusion or after the epiphyseal fusion. So after epiphyseal fusion, the treatment is traction. In early arthritis, patients usually come with a deformity which is correctable. So with continued traction, the deformity will get corrected. Or with under anesthesia, you can correct the deformity and put the patient on spica. So this is for early arthritis. In advanced arthritis, there is damage to the joint. So you can do one of these things. You can do a debridement so that you clear the necrotic tissues. That will help the penetration of the antituberculous drugs much better. It also will help to loosen out the structures and your traction will be more efficient. And if there is a fibrous ankylosis in children, corrective osteotomy will convert the fibrous ankylosis into a bony ankylosis, so that the child could grow up, and after the child has grown up, a decision can be taken whether to give the person a mobile kit. In adult advanced arthritis, debridement, excision arthroplasty is a good option. Arthrodesis can be done, and if there is reduction, you can reduce. If there is dislocation, you can reduce the dislocation, increase it, and subtrochanteric osteotomy if the arthrodesis or the fusion is in a bad position. Extraarticular procedure of osteotomy can be done at any age, and if there is a bony or fibrous ankylosis, a subtrochanteric osteotomy will help correct the deformity, and if in a fibrous ankylosis, it will help go in for completely. So excision arthroplasty is a safe procedure. It's an interval procedure in total hip arthroplasty, and it is a permanent procedure in an old fragile individual. So arthroplasty, we are not going to this. Yeah, this is one clinical example I will give you. Why I have put this X-ray is, whenever you are diagnosing a hip pathology of degenerative arthritis secondary to rheumatoid arthritis or due to avascular necrosis or an old healed herpes or primary osteoporosis, just check that the patient is not a tuberculous patient. This patient presented to me just 2 months after the surgery, after the total hip replacement, and you can see that there is a loosening, and this was a septic loosening 2 months after the index surgery. So we did a excision. We wanted to do a two-stage procedure. The cup is already inside the acetylene. We wanted to do a two-stage procedure. So we removed the implants, did the thorough debridement, and sent the tissue for biopsy. It came as tuberculosis. We did an excision arthroplasty. She is an old patient, thinking that we could do an interval excision arthroplasty and then convert it to total hip replacement later after adequate anti-tuberculous treatment. But she was comfortable. She want another surgery, so she is happy walking around with a walking frame. So the lesson we learn is that not all hip pathology are tuberculosis. There are a lot of pathologies in the hip which will look like tuberculosis, and the diagnosis has to be established only with corroborative findings and with associated clinical findings. This question, Piyush is available or no?
I think he is not available.
Okay, fine. Anyone else?
Dr. Bharanidharan?
Bharanidharan still can.
Yeah,
Yes, available.
Interested in taking up this. Now we can just I will give you one minute for this. Just write down the findings. Both hips.
Noted, sir.
Okay, I will give you another 1 minute. You can write down the possible differential diagnosis.
Dr. Bharanidharan, have you?
Sir?
Over?
Over, sir.
Okay, thank you. We'll discuss about this case little later. And this is a case of rheumatoid arthritis. Why rheumatoid arthritis? The joint space narrowing is uniform. On both sides, you see that the joint space narrowing is uniform. There is peri-articular osteoporosis. These are the findings, and this patient went for a total hip replacement. And this is again, can anyone take this?
Dr. Rupesh?
Rupesh?
Yes, sir. I'm available, sir.
Can you read the finding?
Just write down the findings and the differential diagnosis.
We will give you 2 minutes for that. If you finished early, you tell me.
Yes, sir.
Fine. Are you done?
Yes, sir.
Okay, fine. Thank you. Go well. So this is classical avascular necrosis with degenerative arthritis. These are total. Yeah, this case, anyone want to try? I will tell you. See, this is a case which can happen in tuberculosis as well as in rheumatoid arthritis. So, what will conclude the diagnosis is the corroborative finding. If this patient is having multiple small joint involvement, you should think about rheumatoid arthritis. If this is unilateral, only one joint, then the difference is very, very difficult. If the other finding, if you can get an aspirate and get a PCR, then it is tuberculosis. So it becomes very, very difficult. And this finding you will get both in tuberculosis as well as in rheumatoid arthritis. Yes, now we will come to the discussion on Bharanidharan. Now we can come up. You can tell us what are the findings
Differential
and what are the possible Bharanidharan.
Dr.
Sir,
Bharadharan, are you? Yeah.
Sir, available, sir.
Yeah.
Go ahead.
So it's a plain X-ray of X-ray pelvis AP view.
Okay.
The right hip, joint shows reduced joint space.
Okay. Good.
There is a Daxa articular osteopenia is there.
Hmm. Okay.
Plus, there is a soft tissue swelling is there.
Okay. Fine. Right. What is the diagnosis?
It may be a transient synovitis of hip.
Good. Very good. Then.
Maybe second lead is a septic arthritis hip.
Good. Come on.
And TB synovitis hip.
So transient synovitis.
Septic arthritis. TB synovitis.
TB synovitis. Okay. So these are the possible 3 diagnoses. Okay. I will tell you.
Yes,
I will add a few more points. See, I remember the. Do you remember the? This was a case of malignancy of the brain operated, etc. And the patient presented with this a few days after that. The findings are, you see a lytic lesion here. Are you able to see that?
Yes, sir.
And this lytic lesion is extending like this. And there is a fragment of bone here. And you can see that this fragment because there is a double shadow here. And of course, as you said, there is narrowing of the joint space. And there is some amount of periarticular osteoporosis and okay.
Okay.
With these findings, and because the patient had a malignant tumor removed from his brain, the first diagnosis should be the secondary, right? Agree with me? Agree or not?
Okay, sir. Agree, sir.
The first diagnosis you should think about is, if the history is given to you, you should think about this malignancy, right? Secondaries. The second diagnosis you should think about is, because there is a lytic lesion, you should think about some infection. Okay. As you said, it could be septic arthritis or tuberculosis. We do not know. You can give both diagnoses. So the first diagnosis is secondary. Second diagnosis is tuberculosis. Third diagnosis is septic arthritis. Right? Okay. I will tell you more about this patient. No? This patient was treated on. I put it that this. I put it in red. ATT. This patient was started on ATT before coming to us without a diagnosis. Never start ATT without a diagnosis for 2 reasons. One is you might be unnecessarily putting the patient on ATT and you will be contributing to some extent, to your extent, the development of drug-resistant tuberculosis. The second thing is, if the patient develops a problem with this liver, then you probably have no escape. This patient may have, because there was a recent case in Kerala where a doctor had to pay a compensation because ATT was started without a diagnosis. So if you have a biopsy, if you have an PCR, then you can start ATT. But this patient, we did a biopsy and it was proved as tuberculosis. We did a biopsy on the left knee that was also proved as tuberculosis. Biopsy proved tuberculosis. We started an antituberculosis. Okay, it's fine. Thank you, Bharanidharan.
Thank you, sir.
So the lessons we learned from this are when the patient is put on steroids, the avascular necrosis is also another diagnosis we should get out of because patient was on steroids for some time. Not with just 2 months, but that also should be one of the possibilities. So AVN and tuberculosis. I already told you that tuberculosis can become unmasked when the patient is put on steroids or any immunosuppressants. So multiple joint involvement is more common after steroids. When a patient is presenting with multifocal tuberculosis, the possibility of a HIV or other immunosuppression should be thought of. Right? Yeah, who is coming here, Tuba?
Dr. Rupesh.
Rupesh, yeah. Tell me
Sir, yes.
the diagnosis.
Sir, in this case, since the patient has fever and the ESR and CRP are raised, my first differential diagnosis would be pyogenic spondylitis.
Okay, very good.
My second would be tuberculous spondylitis, sir.
Very good.
My third would be metastasis or a primary tumor of spines.
Okay. Your first two diagnoses are correct. Now, the reasonable way of thinking is that it could be a pyogenic osteomyelitis, or we are usually taught, when there is a juxta discal involvement, the diagnosis should be tuberculosis. Why? The disc, the vertebral arterial supplies the adjacent vertebrae. One vessel comes and supplies to adjacent vertebrae, and when there is an endarteritis, tuberculous endarteritis, it will produce a avascularity of the disc. So the disc is the disc space narrowing and disc pathology, disc infection is most common in tuberculosis. So you should think about tuberculosis. But why I put these cases, the history is very short. In a few days fever, the patient developed weakness and the ESR/CRP are raised. And we are bound to think about it, to think as tuberculosis. But this patient, we opened and curated out the disc space. There was a small sequestrum. I already told you that when there is a sequestrum, it is unlikely to be tuberculosis. There was a sequestrum. We sent it for biopsy. It came as pyogenic osteomyelitis. We put the patient on antibiotics, only antibiotics. And the patient became all right after a few months. A few months continuous antibiotic was necessary. He was totally got all the weaknesses relieved. We did only a biopsy open and did the curettage. Okay, so this was osteomyelitis, not tuberculosis. And a word about total hip replacement in tuberculosis. If this question is asked in the examination, there are few results there. Few people who say that in acute tuberculosis, you can do a total hip arthroplasty. But this is what Julie says. Long-term follow-up results are established. Until long-term follow-up results are established, we may not agree with this statement of Wong et al. Wong et al. Has said that tuberculosis can be treated with total hip replacement in the acute setting. Okay, thank you. And if there is any question, the moderator, Dr. Sastha, can call upon. Thank you. I think it was useful for you.
Sorry, we didn't have any messages so far in the chat session.
No messages. Nobody.
Yep.
No problem, sir. As a moderator, I have some questions, sir. Shall I ask, sir?
Yeah, please.
Yeah. So my question is, sir, you told that starting an ATT before making a histological diagnosis is wrong. You have to make a histological diagnosis, then only start it. Now, in a given case where X-ray finding is suspicious of tuberculosis, MRIs show some evidence of soft tissue swelling, effusion like that. Still, we are suspicious of tuberculosis. In that case, will you do a joint aspiration, sir, or will you go for an open biopsy, sir?
Joint aspiration is good enough. If you don't get a
joint aspiration,
joint aspiration and PCR. PCR is
how will you do it? How will you do it, sir? What needle you will use? What approach you will use?
For the hip joint,
you
anterior approach, not just lateral to the palpate the femoral artery.
Femoral artery and then go lateral.
Little
lateral.
Vertically down. Just push it.
Now, any specific needle, sir? You have any specific needle, sir?
Needle which can reach the
Venflon? Venflon, something like a Venflon needle, sir? I mean,
it should be a solid needle. Venflon may not go till there. It may not pierce the capsule. I have not done it, but the needle, ordinary needle is enough. Just push it down into the bone and we will aspirate.
Okay, sir. And will it be able to get about how much, sir? Probably will be able to get, sir.
See, if there is effusion, you will be able to get a few cc of
collection. Have you gone through the lateral approach? Is there any way to go from the lateral, from the trochanter region, from the lateral approach?
No, I have no idea. I have not done it. I don't.
Okay, sir. That is my first question, sir. Aspiration. Second, my question is, in a given case, when there is a severe soft tissue swelling, whether it is advisable to go for a joint debridement alone without going for a replacement surgery. Just go joint debridement, remove the diseased portions, then put a traction for a few weeks, and then ATT. Is it enough, sir?
That is fine.
Is it a procedure advisable?
That is the procedure. See, in an adult, when there is a severe joint damage, that is stage 2 arthritis, you have to do a joint debridement. And this joint debridement will clear the area and it also helps the drug to penetrate that area. In addition, if you put a traction, the patient will not develop a deformity. The idea here is to prevent deformity so that the patient can walk around for some time till he gains some time for giving him a mobility.
Okay. Okay, sir.
There are some questions here. No?
There is. I think you have missed one slide, sir.
Yeah, we'll do that. I'll just go through that. Go back.
And there's one question from Dr. Jagadish. He has asked when we are safe to do a total hip replacement in TB.
The present recommendation is that patient should be on antituberculous treatment for 6 months, and then you can do a THR. And when the patient is when you have done THR, he should be covered with antituberculous.
Okay.
There is in spine. In tuberculosis of spine, we do a debridement and fix it with a cage. There also we put an implant, but that is different. People say that the tuberculosis they do not produce any slimy layer, and so it can. That is not true. But even in a normal, uncomplicated, safe total hip replacement, the first foremost complication is infection. Agree?
Yep.
Yes.
Okay. So then, how can you deliberately put it in a tuberculosis? So it's not. There are few people who are doing. As I told you the last slide, there are few people doing, but recommended is at least 6 months antituberculous treatment, then do a total hip replacement and cover the area post-operative period with antituberculous treatment.
Okay, thank you. That's the next question from Dr. Bala Kamesh. Why he has asked why we get wasting of muscle in TB hip apart from the duration of the disease. Does the organism have any impact on the protein loss?
Yeah, see, I don't have an answer for this, but only possibility is that these tuberculosis patients are having tuberculosis because of some sort of an immunocompromise. It could be a protein because they have protein loss. Generally, wasting occurs in the proximal muscles. If the patient is having a problem in the knee, the proximal muscle is thigh muscles. Quadriceps goes for wasting. And in the hip, you should look for wasting in the gluteal region. It's the proximal muscles which go for wasting. Okay. Organisms do not have anything to do with protein loss, but I definitely don't have an answer for this. Why the patients develop wasting of muscles, I don't have an answer.
Okay, thank you. Next question from Dr. Narendran. He has asked how long to continue traction in young case symptomatic adult suspecting TB, and he has also asked, can we start ATT without a biopsy?
Yeah, I will answer the second question first. You don't need a biopsy, you need an aspiration. It's enough if you do an aspiration and PCR. PCR is diagnostic. Okay, so that is the thing. How long to continue traction? See, traction, the purpose is to distract the joint so to give comfort to the patient. So we usually give traction for about 3 weeks. And if you put the patient on traction for 3 weeks, his deformity will get corrected depending on the stage of the disease. And then, so you can try traction as a method of treatment only in synovitis stage or early arthritis stage, or in some late arthritis stage where the deformity is not has become fixed. So 3 weeks, the standard rule is 3 weeks traction, and then start mobilizing the hip and continue in traction. So you put the traction as well as mobilize it every now and then. And after 6 weeks, you start mobilizing the patient partial weight bearing. And in about 12 weeks, the patient should be able to bear full weight bearing. Okay. So I will go back to the.
Yeah, thank you. We have another question from Dr. Vishal. He has asked the treatment protocol in advanced TB hip in children.
Yeah, treatment protocol is first start antituberculous treatment. Okay, when you diagnose it. And the second is if the child is small, very small, no, you can put the child on hip spica in the corrected position, or put the patient on traction and continue the traction as I have said in a synovitis for so many days. If it is an early arthritis for so many days, or in the late arthritis is only to correct the deformity or to bring the deformity to a less condition.
Okay. That's another question from Dr. Ananda Narayanan. He has asked, is there any contraindication for arthrodesis apart from active infection, sir?
So you can do arthrodesis even in active infection. See, when during the days when there was no antituberculous treatment, effective antituberculous treatment, arthrodesis was done as extra-articular arthrodesis. It is worthwhile that you go through that chapter in Campbell and read what are the ways of doing extra-articular arthrodesis. Pubic, etc. It's worthwhile because for theory it's necessary. Now it's no longer done. But intra-articular arthrodesis is now done. You do a debrima and do an arthrodesis. You can just pass it through the from the profounder into the neck, into the head, into the acetabular. So compressive. That will help. There is no contraindication for doing arthrodesis as a part of arthrodesis in active infection after doing debrima.
Thank you.
Okay, wanted to see that one more X-ray, no? Two more.
Yeah, one more X-ray, I think.
What is that?
There is a bilateral hip, I think. Sir, am I right, sir? Bilateral.
There was one bilateral. There are two X-rays. One is bilateral hip, other is this is one X-ray. Yeah, what is the diagnosis? Who was seeing this X-ray?
Parani or Rupesh? Someone please. Please read the X-ray.
Yeah, someone can read. Someone was reading this X-ray. No?
Is a plain X-ray of pelvis with both hips, AP view. In right hip, there is a reduced joint space and is a marginal bone erosion in both acetabulum and femur head.
Okay.
And there is some subchondral cyst in femur head.
Yeah, diagnosis.
Bilateral arthritis hip.
Arthritis is a vague term. No? What arthritis?
Probably due to tuberculosis arthritis.
Yeah, because we are discussing tuberculosis. See, I put this X-ray for a very specific reason. This picture you can have in bilateral TB arthritis, in bilateral rheumatoid arthritis, or in bilateral primary osteoarthritis, right? With the X-ray, these are the three possible diagnoses: primary osteoarthritis, bilateral, secondary degenerative arthritis to tuberculosis or rheumatoid arthritis. If a patient is coming with a monoarticular hip tuberculosis, it is very difficult. For monoarticular hip rheumatoid arthritis, it is very, very difficult to differentiate it from tuberculosis. That is why I always say that you should have either a tissue diagnosis or a PCR diagnosis, or identify the organisms before you start into tuberculosis. For your information, this was a rheumatoid arthritis patient, polyarticular rheumatoid. We have done a total knee replacement on both sides, and this patient, this side, we have did a total hip replacement. Because there were correlating findings, and we could come to a conclusion that it is because of rheumatoid arthritis, we did a procedure with joint replacement. But without that, without excluding tuberculosis, you should not do a joint replacement. The next slide was. Yeah, this was the next slide. She's only 28-year-old. Who was seeing this? I'll tell you the findings. There is uniform narrowing of the joint space. And there is osteophytes, which indicate that she's already going for degenerative changes. So this is rheumatoid arthritis. She was having other features of rheumatoid arthritis. So this is a case of rheumatoid arthritis, and she is going for degenerative changes. And what will you do at this stage? Rheumatoid, bilateral, 28-year-old. What will you do at this stage? Anybody? Can anyone answer?
Dr. Rupesh?
Yeah.
Dr. Rupesh? Yeah.
Sir, can I go for a bilateral total hip replacement, sir?
Okay, that is what you should not do. See, she is walking around. The next question you should ask is, what is her status? She is walking around. And if you see this X-ray, bilaterally there is an abduction on the right side of the abduction. So she is able to have this X-ray was taken in abduction, but she is able to walk with limbs parallel to each other. Therefore, this patient is having a reasonably good range of movement, and this patient is able to walk around. And she is an active rheumatoid because there are multiple joints involvement. I will put her on anti-rheumatoid DMRD regime for some time, and let her ask for a joint replacement only when in the exam. If you are asked a question, if a similar case comes, if you are asked a question, your answer should be, I will leave her alone for some more time, and let her earn the total hip replacement. That should be the answer. We will not jump into joint replacement. Okay. Anything else?
No, I think that there is no other
questions.
No other questions. Yeah.
Okay. And thank you, everybody. Thank the organizers. Thank the team, Tamil Nadu Orthopaedic Association. And I hope this was useful for the postgraduates. We thank everyone, and we take leave. Okay.
Thank you, sir. Thank you, Dr. Krishna Kumar. Thank you, Dr. Sastha Sharan, for the wonderful discussion about TB hip. It will be useful for our postgraduates. We thank Ramesh from Olympic Group for sponsoring this event. Thank you very much, sir. Thank you.
Thank you, sir.
Thank you.
Thank you, thank you everyone for giving me this opportunity.
Bye-bye.
Yeah. Bye.
Yeah.
Bye.
Thank you, sir. Thank you. Thank you very much, sir.
Thank you, sir.
Jayesh, you can give end. Jayesh?